tried to go through this rather quickly. I did do a lot of this in a webinar a couple of weeks ago. Um, Wanted to even make it more concise and efficient for us in the advanced series here, but to go over the main points, same main points that we talk about. So the idea is how can we care for traumatic stress in children in the primary care setting? Um, there's, yeah, a plug for CalMap, our upcoming educational series. I don't have any financial disclosures. And here's our learning objective. So the first thing is, what are the core features of childhood traumatic stress? And that's the first objective because it's something that's often missed, and we'll talk about that. So we want to know what it looks like so we can identify it. That's the second one, is how can we help prevent it? So what are the risk factors, and how can we identify those and intervene early? And and then how can we identify when kids have experienced when they've for kids who had traumatic events, and then those who are having symptoms, how do we manage those in the primary care setting? So I just up front want to acknowledge some people that have done some really great work in this area. The Pediatric Integrated Post-Traumatic Trauma Services in the Department of Pediatrics at the University of Utah developed a child traumatic stress care process model where a lot of this is adapted from, and it's really what we're talking about today, how to care for PTSD in kids in the primary care setting. So I want to acknowledge the great work that they've done. And then American Academy of Pediatrics and the National Child Traumatic Stress Network, wonderful resources for providers, for families that I'll be referring to as well. Okay, core features. One, a traumatic event, right? And so this is the word, trauma and traumatic has been kind of expanding over the last 15 or 20 years. But when we're talking about terms of traumatic stress in kids, it's events that either cause or threaten or feel like they're going to cause significant harm to them or to someone that they're with. And for kids, it can be something they learn about if it happened to a caregiver or someone in their immediate family, but it's usually an event that either they witnessed or they experienced themselves. This is a lot more common than I think we may even realize. An estimate's about 80% of kids have experienced at least one or will experience at least one traumatic event in childhood. And that's a lot. So it's very, very common. But on average, this is a really important point, about 15% of kids exposed to a traumatic event will go on to develop PTSD. So it's not every kid. And that's where this kind of model of a pathway of how we care for this comes in, because it's not, everyone gets treated the same. Two kids who have experienced the same traumatic event, one may develop no symptoms and need one level of care, and another may develop significant symptoms and impairment and need another level. So how do we kind of figure that out? And then here are the core symptoms of traumatic stress in childhood. Kids may have all of these, and that would be, if they have all of these for longer than 30 days, that meets criteria for PTSD, but it's not so important that we're worrying about the diagnosis, just picking out what the symptoms are and what they can look like. And so it varies depending on age as well. So intrusive thoughts, this can also be like we call re-experiencing symptoms. These can be things like flashbacks, pretty dramatic when that happens, but more commonly things like nightmares, even increase in frequency in nightmares, and playing out experiences in their play can be common ways of seeing intrusive thoughts. Avoidance, now for little kids, it's really hard to avoid things. They're kind of told where to go and where to be, but that may just be getting upset when they are or dysregulated when they're talking about or being around reminders, or as they get older, they may be actually able to avoid things that remind them. Hyperarousal is the third one. This can look like irritability, anger. It can look like insomnia, very difficult time falling asleep. You can see an exaggerated startle reflex. I think the most commonly thing you see is just a lot more dysregulated emotions like in irritability and anger. And then the fourth one is negative mood or thoughts. And these are things like thinking that they're bad or that something is wrong with them, thinking that the world is unsafe. And this is importantly, this isn't like, this is something that's an overgeneralization of something that happens. So an example is if they were in a car accident, they start thinking that all cars are dangerous, which we know cars can be dangerous, but not all cars in all situations involving cars are dangerous. So that's an example of a negative cognition or thought that is a core symptom as well. So those are the symptoms, those are the things we want to look at. But oftentimes, maybe either because, it's easier to catch or something we have more experience with, but a lot of PTSD and childhood trauma can be associated with a lot of comorbid illnesses as well, like depression and anxiety and oppositional defiant disorder, substance use disorder. So you may actually see these things first and say, oh, this kid has depression or this kid has anxiety. That's why it's really important for these kids to ask about traumatic events, because there may be an underlying traumatic stress response that's part of this presentation. So just the important point here, trauma and PTSD can be easily missed because it can be masked by these other things and can look like these other things as well. Okay, the steps of how to address in primary care. Four steps. Let's start with prevention. This is something I know you all are already doing, so it's kind of preaching to the choir. We want to screen for risk factors. I think it's really helpful to have a standard social determinants of health questionnaire. I really like the SEEK one. If you all aren't already using one or have a favorite one already, it's validated as a trauma screen for kids aged 0 to 5. It stands for Safe Environment for Every Kid. This one page, there's an example here. It asks about those risk factors for trauma, including parent substance use, unstable housing and financial insecurity and things like that. So it asks about the risk factors and then gives you the opportunity to acknowledge, ask about need and desire for assistance, and then provide relevant information and support in those instances. And for little kids, it also asks about some traumatic experiences as well. So it's kind of a screen for the events, but also for the risk factors. And of course, we know that younger kids are also more likely to experience traumatic events. So it's especially important to screen for risk factors early, intervene early, and you can really have, hopefully help prevent these things from happening. Second step, identifying it. So you're not gonna identify it unless we ask a lot of times. I mean, sometimes they come to you and they say, this happened. And so it's pretty easy to pick up on. But a lot of kids in communities where it's just all too common, the families may not even think to bring it up as part of, even for a behavioral health visit, may not say, oh, by the way, there was a shooting in our neighborhood last week. So that's why it's important to ask. And it's not something that's recommended to do universally in every single visit. And that's for reasons like, because it can, create undue feelings of blame and things like that. But and also it's just not it's just not been there's not the evidence for it so far at this point. But in specific populations, so if they're in a really high at-risk community, such as kids who are in foster care, kids with developmental delay, kids who are refugees or have housing instability, those are people we want to be screening for regularly. If it's there for a behavioral health visit, like I said, they're having trouble sleeping. Oh, by the way, this happened as well. We want to be asking in those kids. So if you're, and then another here on the next slide, another way, the way to ask is to use a screener. You can just ask, hey, has anything scary or upsetting happened to you recently or in the distant past? You could definitely do that with the kids and the families. You can also use a screening tool. So this is one screening tool, the Pediatric Traumatic Stress Screening Tool. This was developed at the University of Utah group. I really like it. The first two questions are about trauma exposures. And again, sometimes violent, very scary, upsetting things happen. And this could be something you saw. It can include some examples. They list some examples, and then did it happen, and have a blank space for listing what happened if they want to do that. So those are the first two questions. So it's a trauma exposure screen. So you can use a screening to make it more efficient. Maybe you do it in your waiting room for every behavioral health visit. maybe you're working in a foster care clinic and you want to do it for every visit. But having some tool to use is really helpful to make sure you're not forgetting to ask. This tool also has trauma symptoms questions that we'll get to in the next step. There's a lot of other screening and trauma symptom rating scales out there, like the UCLA PTSD Reaction Index is a great one. Childhood PTSD Symptom Scale is another one. This one's free, but if you have another favorite one you like to use, having a measurement-based tool to use, just like we do with depression and with the PHQ-9 and anxiety with the GAD-7, is really helpful for making things efficient and making it standardized and helping guide our decisions, which we'll get to next. The SEEK, like I mentioned before, is great for young kids and asking about trauma exposure. Okay, so we've done what we can do to help prevent. We're asking about it and identifying times when it's happened. And now when it has happened, how do we triage to see who needs what level of intervention? So I really like this model coming out 20 years ago by a group in Connecticut called the 3 stages of trauma recovery. Each phase is kind of sequential. You have to do the first one to move on to the next one, but it's kind of summarizing how kids can heal or recover from trauma. And the first one is stabilization, and that's really all about safety. So if we don't establish safety, then we can't move on to the other phases of recovery. And this one I know you all are doing, and so I just want to acknowledge that and thank you for the work you're doing with the safety part. We'll discuss that briefly, but we have to address safety first. And then after that, you can get on to how to help move forward beyond that. And for that, we'll ask about symptom severity and functional impairment. So addressing safety, it could go without being said. Report abuse or neglect if suspected. In California, this is done through county reporting hotlines, so the directory link is there. And the other part of it is screen for suicidality. These kids are at much higher risk of experiencing suicidal ideation and actually attempting suicide. So you can use a screening tool, again, so we don't forget to ask and it's standardized. Another reason why I like the PTSST is because it's asked about traumatic experiences, asked about symptoms, and then it asks about suicidality in the last question. So, but if you are already doing a PHQ-9, which asks about suicide or the Columbia Suicide Severity Rating Scale, whatever tool you're using, we want to make sure we're asking about suicidality in this population of kids who have trauma exposure, just to make sure we're establishing safety. So when there's a yes to that question, I want to make a plug for our suicide clinical pathway that we have on CalMap. Please see our website. It's really great. Shelley and Eileen recently gave a talk about this, so I won't go into that in detail, but please see that. It's another one where you can use a tool to help do a risk assessment and then to help guide and triage your treatment. Okay, now we've asked about safety, and now we're getting the sense of what is the level of severity of symptoms and the level of impairment. So if you have enough experience with doing this, you don't have to use a tool to do this. I honestly don't use a tool because I do it so often. I ask about the symptoms and then I get a sense of how severe they are. But if you're not as familiar with, or just to speed things up, I also have more luxury of time. If you want to give this a rating scale like the PTSST or another rating scale, another tool, it could help, make things more standardized and make things more efficient. Give it to them in the waiting room, fill it out, track it over time. But anyways, you want to get a sense of how severe the symptoms are. So with the PTSST model, you could score it, or you could just sort of look at the form. If there's check marks all are on the right side, then it's more severe. If they're all on the left side, it's more mild. If they're kind of in the middle, it's more moderate. You can score them up, and there's, kind of areas where you can say it's more mild or moderate or high risk. But just get a sense of how severe the symptoms are, and then consider functional impairment. So ask, how is this impacting their life? Is it affecting their sleep, their health? Is it affecting their home life? Is it affecting them academically? All right, now you've got a sense of symptom severity and functional impairment, and that will help guide your levels of treatment. So level 1 is the overall gist is education. So providing psychoeducation and anticipatory guidance. This is where I want to pull in the resources, because we don't have to reinvent the wheel here. There's some really wonderful resources for parents and families that you can just hand out, or you can go over with them. And I'm actually going to change over my screen to this here to show you what it looks like. So this is the NCTSN Understanding Child Traumatic Stress, a guide for parents. And it's kind of summarizing in lay terms what we're just talking about here. What are the symptoms of trauma in the kids? And that, it can depend on age, but this is what things it can look like so that families understand and can have empathy for what's going on in their kids. An overview of what treatment can look like, and then what can they do at home, and the simple steps to follow. And it's essentially, it's the pyramid that we're talking about for recovery. It's establishing safety, it's helping them process by allowing them to talk about it, and it's reintegrating them into their everyday life. And that's the overview of what these steps are. But one page, front and back, and then a little section here, how to get support in school. So also another huge source of support in terms of treatment for these kids can be through the school system. So that's a great handout. And then another one is age-related reactions to a traumatic event. So how they can look different in kids at different age, at different stages of development. So preschool and young age children, different ways it can look like in them, for school age children and for teenagers, and then how to help. And again, it's the same principles of how to help, but it's establishing safety, and it's helping them process and then reintegrating. But it can look a little bit different depending on their age or developmental level. So those are some really helpful tools, educational tools. And then there's an emotion coping skills. I really like the CalMap handout for this, which is here. It's a one-page front and back again. It's got videos describing like cognitive behavioral strategies for coping emotions, a video describing the dialectical behavioral therapy strategies for managing emotions, another community resource, or tools for teenagers to point teenagers to. There's coping skills toolkit that anyone can do, taking 5 deep breaths, taking a walk, just some ideas of how to help people regulate their emotions, because that's really what's going on is when people are triggered is having dysregulated emotions. So those are some really helpful level 1 interventions that we can do with mild symptoms or minimal functional impairment. These are things, or really anyone, we want to be doing this. Okay. Just another quick note about education, how we're talking to families can make a big difference. I really like the AAP's help mnemonic. So expressing hope, like things can get better, expressing empathy, validating how they're feeling, the caregivers, what they're experiencing, and the kids as well, using their language, say, I'm with you, we're going to do this together, and asking permission so they have a sense of autonomy and control, and coming up with a plan like we're talking about today so that they have a sense of confidence that things are going to be moving forward. Doing this with the caregivers in a parallel process as the parents are trying to do this with the kids is you're modeling this type of behavior and helping the parents do the same thing with their kids so that the kids feel supported at home. All right, then level 2, and we'll get to kind of who gets level 2, who gets level 1. Level 2 is really referral. So there are evidence-based treatment therapies for PTSD in kids. They have common components. There's some different types, but they have common components of they're developmentally and culturally sensitive. They're based on strength and resilience and skills and safety. They should involve a parent or caregiver as long as they're not involved in perpetrating the trauma, and helping them overcome avoidance. And there's a couple of types listed here: trauma-focused CBT, child-parent psychotherapy. There's a list of all types of therapies from nctsn.org. You can also put in, there's a search engine there. You can put in your zip code and you can look for places that provide these different types of therapy. Okay, this is kind of a summary, our clinical pathway, a summary of all the things I've been talking about in one place. I know it's kind of busy, so we'll walk through it. First step, identify. So asking about trauma exposure. Okay, This again, in populations that are at high risk, behavioral health visits, always asking about it, or if they obviously tell you that it's happened, then you already know. Then the first step in triaging is addressing safety. Does it need to be reported? Is there suicidality, and how do you manage that? Okay, and then you move on to symptom severity. Again, you can use your clinical judgment, but you can also use a rating scale tool. Are they in the mild group with minimal functional impairment? You want to do level 1, which is the gist of it as education, coping skills, the things we talked about, and following up. And if they're in the moderate level or lots of functional impairment, you want to still be doing that, but you also consider referral therapy. They're in severe level, you want to be referring them to evidence-based therapy. Okay, some caveats to that real quickly. Young kids, it's a much more difficult diagnosis to make. So the gist of it is, if they've had a traumatic exposure and they have any symptoms, whether mild or not, you want to consider making a referral. And then use your clinical judgment. There's the types of trauma can influence your decision, who you make a referral for and who you don't, if there's barriers to care, if there's protective factors or not, if there's a high level of parental attunement, to have a high capacity or low capacity to support. So think about those things when you're considering what level of support you want to try to give to families. And just make a quick plug for our CalMap Care Coordination team. If you have folks that lots of barriers to care, or other risk factors, things that we can help with, please reach out to our care coordination team that can work directly with the families to address those. Okay, and then you're like, well, you're a psychiatrist and we're doctors or we're medical providers. What about medication? Well, I purposely left that out, okay, because the fact is that there is no evidence for first-line use of medications in pediatric PTSD. And actually, a lot of times medications get overprescribed and can cause more damage. And we know that kids who are in the foster care system are much more likely to be prescribed medications like second-generation antipsychotics that may or may not be actually indicated and can cause a lot of side effects. Symptoms can look very similar, as we've discussed, to other diagnoses, but they may not respond if they're related to trauma to the same kind of treatment. So that's, again, where it goes back to asking about trauma. But be careful with medications. There can be comorbid conditions. There can be pre-existing conditions that need to be addressed. So it doesn't mean you can't use medications. Just be mindful and consider, you can consider adjunct medications if symptoms persist after you've started treatment for the trauma. So my approach is ensure they're receiving evidence-based trauma therapy. And at the same time, one of the things I do is address sleep. So sleep hygiene first, of course, addressing trauma triggers at night. But you can, if you're doing those things, you're still having a lot of hard time sleeping because that has such a huge impact on emotion regulation. You can consider things like melatonin or a trial of an adrenergic modulating agent like clonidine or prazosin, which have shown to have some benefit in some kids with sleep-related symptoms of traumatic stress. Second phase is then, as you're doing treatment, evaluating for and treating comorbid conditions as you see them there. And you can start to separate those as you address sleep and kids are getting evidence-based treatment for their trauma-related symptoms. Overall, please be conservative, limit complexity, discontinue medications if they're not working rather than just adding something on. Use a shared decision-making model, informed consent with appropriate caregivers or proxies, and assent from the kids when indicated. Summarize. Most children will experience a traumatic event. A minority will develop symptoms. That's a good thing, but it gives us work to do to figure out which ones are experiencing symptoms and which ones aren't. It's especially common in kids in foster care, refugees, kids who are unhoused, developmental delay. Screen for risk factors to help prevent. Screen for trauma, especially in at-risk kids with mental health complaints, so we don't miss it. Consider using a rating scale to help triage for treatment. And then just acknowledging, again, education and safety have a huge impact. And I know you all are doing that work, so thank you for doing that. Here's some of the resources I talked about, if you want to look at those, and then my references, and then questions.
Wonderful. That was great. Thanks, Joe. One question that came through is there a difference between a distinction between acute symptoms and chronic symptoms after a traumatic event?
Not really, I would say. Like, there is, I appreciate you bringing up the timing. I didn't talk about that, that symptoms can come up later. Like they do not have to come up at the time of the traumatic event. They can come up much later. So, in terms of following up, what we usually recommend is within like 2 to 4 weeks after, after the initial visit to check back in then and see if symptoms are continuing or if they've developed then, and then another 4 to 6 months after that. And symptoms can come up later on as well. And that's part of the education of families. Like, look, this is a process. Some kids go through it quickly. Some kids go through it much more slowly. Some kids it's delayed. And but the symptoms can look the same much later on or immediately after. They're obviously more common immediately after and much more prominent sometimes, but can definitely persist for years. And including, yeah, all the things we talked about, the avoidance, the re-experiencing, the negative mood and cognitions, and the hyperarousal.
Absolutely. There was another question here for families with Medicaid. Any advice on how to get access to evidence-based trauma therapy? Right.
Yeah. Yeah.
And
This
so,
is the hard part. And um, the advice really is consider all our options. So there's that
Mhm.
option of how to get help in school. So, one thing I point out here is that especially for kids with moderate symptoms or, functional, some like moderate functional or some functional impairment and mild symptoms, referral to therapy, I would say take what you can get, right? Because sometimes brief or non-specialized types of counseling or therapy can be really helpful, just helping kids process what
yeah.
happened, not necessarily like following the sort of manual for an evidence-based treatment model. Take what you can get. But for those kids with really severe symptoms or high functional impairment, we want to try everything we can. And to do that, I would say, um, uh, go through the access line in your county for kids with Medicaid, go through their managed care organization, and advocate for evidence-based treatment, which again, there's a list here and there's a list from the National Child Traumatic Stress Network. And then please, again, don't hesitate to use our care coordination team.
Yeah.
Um, they're excellent at knowing what kids need, and also, we'll take what you have figured out what they need and help them get that through whatever resources we can find.
I've sometimes had luck going through the IEP process and asking for an IEP, like under I don't know, other health impairment or
Mhm.
emotional disturbance at times, and to get educationally related mental health services or ERMs. And that's just a way of getting like weekly, like specialty mental health care at school. And so I've sometimes had luck going that pathway as well. And that just tends to be accessible for families because it's often hard to get them in other ways. But that's another pathway that I've sometimes used. But in the interest of time, I feel like we should, at this point, switch over. And thank you so much, Joe, for this great talk. And I'll try and email back out with some of these like resources that have come up. Um, but I want to switch over to our case discussion. I believe Vivian, did you have a case that you want to share with us? Just a couple, just a quick summary, and then maybe some of the questions that are still alive for you that we could discuss
Um,
this.
yeah, thanks. This is a child who's now 9 years old.